Oncology Club, Bangladesh, a platform for all fighting against cancer. It is the founder of Bangladesh chapter of the SAARC Federation of Oncologists, the only platform of oncologists recognized by the SAARC Secretariat. This organization is moving forward with the aim of improving oncological care, services, expertise in the country to ensure a standard of care and treatment for the patient of the country. Now, it's time for the second session of the day, and that's it. SAARC session discussing on the scopes and challenges of SAARC treatment guidelines for common cancer. This session will be chaired by Professor M.A. Haisa, Patron SFO, President Oncology Club, Director Bangladesh Cancer Society and Hospital, Professor A.M.M. Shariful Alam Sir, President SFO and Head of Department of Clinical Oncology, Ahsania Mission Cancer and General Hospital. Session will be moderated by Dr. Mustafa Aziz Shumansa, Associate Professor and Head, Department of Oncology, Kurmitora General Hospital. Now I am requesting our chairman and moderator to grace the dais.
So thank you. So may I have your attention, please? So may I have your attention, please? We are going to proceed with our second session. This is a very important session, SAARC plenary session. So here it would be a thought-provoking sessions. Let's see whether there is scopes, what should be the challenges for developing a SAARC treatment guidelines for common cancer. So may I request all the SAARC dignitaries. So at first I would like to request Professor Govind Babu, ex-president of SAARC Federation of Oncology. Next to him, Professor Ijaz Masood sir, ex-president, past SFO. Professor Vivek Acharya from Nepal, past president of SFO. Sanat Wangasurya, President of Sri Lankan College of Physicians. Professor Ahmed Ijaz Safi, so from Afghanistan. And Professor A.F.M. Kamaluddin, he will represent Bangladesh. So you can see one chair is left. It is for Namkha Dorji. He is coming from airport, so please keep the chair over there. He is coming. So you can see we are very blessed, rather we should say privileged, to get all the SAARC dignitaries. You could see the SAARC leaders over there. The patron of SAARC, Professor M.A. Haisar, is there. The current president of SFO, Professor Shariful Alam, and you could see all the past presidents, those who have represented their countries. So let's start with this picture. Everyone know what does saga means, but I am not talking about this saga. I am talking about this saga, the South Asian Adaptive Guidelines. So whether it is reality, is there any possibility? Let's see. So at first, start with a very easy question. So do we need guidelines in oncology practice? So let's start this question from host country, Dr. A.F.M. Kamaluddin. So do you think, do we need guidelines?
The answer is yes. For clinician perspective, from patient's perspective, from legal perspective, from social perspective. For clinician perspectives, we know that the disease is heterogeneous, so we need to have a standardization of the treatment. For patient's perspective, patient goes to somebody, different thoughts become confused, so we need it. For legal, because it gives you legal protection. And social, so it gives you a social status that we are standardized the treatment. So definitely we need it.
So is there anyone in the panels who have different thoughts regarding these guidelines, for policy?
I would like to add, yeah, I agree with Prof. Uh, you know, as already been said even yesterday, 24% of the population live in SAARC region. And the guidelines, whatever the protocols done in high-income countries, with all the facilities, almost everything is there, and not always applicable in our setup. So, yes, the answer to your question is yes, we need to adopt our things,
So
our
the
own thing.
later part of the yes, so we are taking the part that we need yes, so we are coming the later part. So we need these guidelines, Dr. Sanath. So that is a common decision from all the panels, right? I could take.
So Suman, let me play the devil's advocate here.
Yes.
So today in the era of precision medicine, you have so many diverse things. For each patient, you have to give that precise medicine. So, I'm just being a devil's advocate. So we may not be able to have guidelines for such narrow diseases. So that
sir,
is
you
one.
could see this is the first question. This is a very easy question. So I just want to take yes or no answer.
Yeah.
Okay. So everyone knows that how guidelines helps. See, it helps decision making to provide the current best practice. So, but the real problem is all the guidelines are from the Western world. You could see the ASCO, NCCN, ESMO is there. Even the Pan-Asian adaptive guidelines is there, but they are not reflecting the Southeast Asian part. They are more dominating by the China, Singaporeans, Malaysians, so they are not reflecting our peoples. So, which guidelines you are using there in your country? So, Govind sir.
So I'm unhappy you didn't put the Indian guidelines.
So the
We have guidelines from the ICMR through our societies for 26 tumor types. We've done it in the last 4 years. It's on the website, so we follow those guidelines. And that is probably most applicable to our region. Of course, we are now collaborating through our Medical and Pediatric Oncology Society with ESMO for the PAGA guidelines. But still, I think the PAGA guidelines are for rest of the world as well, for especially Japan and Far East countries, which may not be totally applicable to our region. So I believe our Indian guidelines that we have is the most applicable to this region.
So thank you, sir. So you are fortunate that you have your own guidelines. What about in Pakistan, Masood sir?
We are following NCCN guideline and ESMO guidelines. Some people are using NCCN and some are using ESMO guidelines.
So Professor Bibek, what's the status in Nepal?
Same as in Pakistan. We use mostly NCCN guideline, and sometimes if we don't get the proper answer, then we look into the ASCO or ESMO. But I think, as Dr. Babu said, Indian guideline would be more applicable in our scenario.
So whether you are using the Indian guidelines or the ASCO guidelines right now?
Right now in NCCN.
ASCO, okay. So the Sanath?
Yeah, we also use NCCN and ESMO as well as ESCO, but we have our guidelines, own guidelines for 2 cancers. That is for early breast and advanced breast cancer and head and neck cancer. We have our own guidelines. Apart from that, we are in the process of developing our guidelines for uterine cervix as well, but we have 2 in hand already done. So when other cancers are there, so we always use those guidelines.
Okay. So Dr. Javed, Afghanistan.
Yeah, I think it is very amazing and great for me because we are just start and we don't have much experience. Unfortunately, as you all know that we just start cancer treatment in Afghanistan, it is something amazing and I confuse because some of our colleagues from SAARC countries, they are supporting us when we have patients we can receive different guidelines, different treatment plan, protocols. So I think it's quite difficult because as we use in Afghanistan, our patient response difference. So I think our patient cannot tolerate or to beat the guidelines from Western. I think we need specific guidelines for our nations. As Professor Kamaluddin also said, we have different problem, particularly legal problem, particularly treatment equipments and resources in our region. So I think I will appreciate if we have a specific guidelines for oncology in the
So
future.
thank you, Javed. So right now you don't have any definite guidelines in your country. So let's see how we can proceed. So Dr. A.F.M. Kamaluddin.
So your question is using, I will say which is popular. In our country, NCCN is the most popular guideline because using is like a buffet, you can select anyone, and there is another group where we are not using any guidelines. So non-adherence to guideline is also a big component in our country, but for the guideline user, the most popular guideline is NCCN.
So Namka, so you're from Bhutan. So what's the
Yes.
status of your country?
Good morning, everyone. Sorry I got late because of the flight and again with the traffic jam on the way. Thank you for having me as a representative from Bhutan. So to answer to your question, it is a unique situation in Bhutan because I am the only gynecological oncologist. And what I do is mostly I refer NCCN guideline and occasionally up to date. So I have to adjust with the equipments, facilities, and the type of patients I get. So to be very specific, the commonly referred guideline is NCCN, which seems practical.
So just a disclaimer, I forgot to get the permission from the learned panelist. So this program is recorded and we will make a manuscript from your discussions, from your suggestions, from our decisions. So let's see whether we could publish it or not. So as Govin sir said, that there are some unique features in this region. So you could see the demography and the cancer statistics, and you could see the SAARC nations over there. So here are the 3 points. You could see whether you do believe the demographics between the Western and SAARC countries is different or not, the tumor characteristics between the Western and SAARC countries, yes or not, and availability resource in the Western versus SAARC nations, yes or not. So I am sure the answer is yes, there is a difference. So I am not going to ask this question. So do you think, having all these disparities, you are using, I am saying that more than 50% of the participants are using these Western guidelines. So do you think whether doing the right thing? Yes or no? No. No. Okay. So let us find our own way. So what are the factors that demands SAARC own guidelines? So let's start with Govind sir.
Yeah, like I mentioned, our own unique demographics, our probably different genomics, which we don't even have data, we've just started. There are 3 of the centers in India who are actually trying to map the Indian genome. So probably we will get a difference. And to quote one simple example, why we need different is the study of lung cancer, which started with gefitinib many, many years ago, called the ICEL study. This was a phase 3, second line in non-small cell lung cancer. So after the first line of chemotherapy, the second line was between standard of care for that physician versus gefitinib. And this was a global study. And the study was negative because gefitinib did not show any advantage. But from India, we had 110 patients on this study, and our patients were doing very well. So at that time, the story of EGFR mutation was not clear at all. So then they went back and looked up why this was. And the Indian population was grouped as Caucasians then. So then they looked up, revisited the whole data, and then gefitinib got approved for EGFR mutant non-small cell lung cancer. And initially they said it was for the Southeast Asian population. Then they realized the EGFR mutation rate was as high as 60%, whereas in the Caucasians it was just 4%. So this I always quote because there's a classical example of a genomic difference in the populations. So I think that is very, very important for us to keep in mind.
So, Govind sir raised these issues, the genomic difference between these trans borders. So, beside this, Ijaz sir, would you like to add some other factors?
Yes, there are lots of differences, and I have found many things, like in head and neck cancer. We had a study jointly with India. It's way back, about 20 years back, and we found that concomitant chemoradiotherapy is not good for that, head and neck cancer. But in Europe and America, that's the standard of treatment. We prefer, and we found it, that neoadjuvant chemotherapy followed by radiotherapy is better in our setup. Secondly, I have found that the doses which we give, I've tried myself and published it in CML, even for trastuzumab and rituximab, all those things. We don't have to give the dose which is being given in Europe and America. We can reduce the dose. And once we reduce the dose, that will be cost effective and less side effects. So we can use all those drugs. I found in CML, giving nilotinib 600 to 800 milligram leads to pancytopenia. But if you give it 400 milligram, I got wonderful results. So we can reduce the dose and we can get it done in all of the SAARC countries. So this needs to be repeated.
So again, you are talking about the patient factors. So beside this, Professor Vivek Acharya, so any other factors?
Yeah, maybe disease burden, such as cervical cancer, is much more common in our part of the world, right? There are very less researchers going for this. So I think we should focus on that point as well, the disease burden.
Yeah, Sanat?
Yeah, guidelines are guidelines. Now, for us to stick to the guidelines, you should have all the resources, isn't it? So, good if we have everything, but in a situation where you don't have the access to everything what is written in the guideline, so the outcome, your capability differs. So I think that is also a factor.
So Javed, anything to add?
I think why we don't have the guideline for our region. I think as I heard that since long time that we need a specific guideline for our region. So why we cannot make it? I think this is a big question for all of us. As all mentioned that 21% of the world population is from this region, so we need guidelines. As I see some colleagues from SAARC countries, as Professor Ijaz Masood said, we use some low-dose chemo. I think it is a good response even for our patient in Afghanistan. If we use the international guidelines, the patients have difficulties. So I think there is different factors. For example, our economic situation, our equipment, our resources, these all questions that cannot fit with international guidelines because they have all these facilities. Unfortunately, we don't have it. So I think I prefer and request all our leaders to work on this, and I hope that we have some output soon. Thank you.
So besides the discussion, what you have found there, the GDP allocation in the health sector, these are another factors. The tobacco distributions is quite different. It is very high in Bangladesh. And the patient presentations, you could see the advanced test presentations is quite high in this part of the world. And performance status, that is also very different from the European part to this part. Of course, the availability and the utility of the targeted drugs, you could see the rate of TKI using over there in this part of world, and the other things you could see over there. So we have very much discussed these things, that the genomic profiles are quite different. I am not going to details. So you could see the approved drugs. We are taking the considerations for our discussions, the lung cancer. You could see the first generations, the price is there. The second generations, the price is there. But third generations, So, Govind sir, what is your routine practice over there? You have already said that Devitinib, right, sir?
Yeah. So we are lucky that India is the pharmacy of the world. So we're getting a lot of good generics at an affordable price. So that is the first thing. Plus, the other thing is we have had innovations. We have used chemotherapy with Geftinib in lung cancer. We've shown that it is useful. And we have used Geftinib with minocycline and shown that it is just as good as adding chemotherapy, better than using Geftinib alone. So these are two examples that what innovations we made. The other drugs, many of these drugs we have generics. Other thing I believe is that we must get involved in global clinical trials. That again gives you access to the new drugs. You have first-hand usage of these drugs. You're better equipped to handle them. And you get that idea of how to do a clinical trial. Many patients are benefited. I think that's an important issue that we must encourage global clinical trials and our own regional clinical trials to be adopted.
So the main issue is that all the drugs that are endorsed in the guidelines that may not be possible from our end due to multiple causes. So we need our own set of guidelines. So let's start the main discussions. How do we implement it in our practice? So what is the guideline development process? Should it be done by a society, by individual or public forum? How do I publicize it? Whether it is website, newspaper, how do you increase this adaptation? So that is the main procedure to develop a guidelines. So let us start first. Who are going to take the responsibility? Is it the society? Is it the personality like Professor M.A. Hai? Or is it the public forum or the conference like this? So let's start with the last one, Namka.
I think the leader of the guideline development will depend from country to country. If the country has a society, like Bangladesh has a oncology society, I think that is the right society, right person to start. But in a country like Bhutan, where I am the only gynecological oncologist and where there is no society, the right person to lead the thing is the National Cancer Control Program as a manager. And can I answer the rest of the question or just one?
Please.
Yeah. And what is the guideline development process and how do
No,
we...
Namka, I'm going to the second question later. Let me get the first question answer from the all audience. So
Okay.
Dr. F.M. Kamaluddin, who are going to take the responsibility? Is it the society or the individual? So considering you know our socioeconomic status, you know everything regarding the SAARC region. So be honest on your opinion.
So, Shuman, it is not that I dream something and I make something. A strong society may not be able to develop a guideline because to develop a guideline, there are some criteria. We need to have some data, we need to do some research. So maybe a society is not capable of doing it. Maybe, or on the other way, the society may take the lead of developing a guideline rather independently doing something because it is not an individual work. Say if I want to develop something in Bangladesh, I can sit with 10 guidelines and cut and paste and make one. That is not a guideline. Guideline is our data. So are we ready for that? Do we have enough data? Are we having an adequate research on it? Then we make a consensus among all and then are we ready to revisit it? Because maybe our initial decision was not correct. After 6 months or 1 year, we decided that we need to modify it. Like, every time you revisit and update it. So if we are not ready for that, we should not do one guideline once in a life, sit together, take 10 guidelines. Normally we think like that. That is not the ideal way of doing a guideline. We must have our data first, otherwise it will never be different from Western. When say Govind was talking about all the points that you said, so that is important to have it. So I think a society can take a lead, but cannot take the whole responsibility of developing a guideline.
Okay. So Zavid.
Yes, I think that this SOFO is a good address for this initiative. I think governments, they cannot do it due to bureaucratic procedures and blah, blah. So I think this SOFO can do a draft, as Professor Kamaluddin said. We cannot copy and paste. We can do something before the developing of the guidelines. We need some research and we need to work for something, then we can come to this point. I prefer to work together and do not sit back. And what I see from my short experience, once again, I want to have guidelines, and I recommend to all our leaders to have their own guidelines. Thank you.
So thank you. The Sanat, who is going to take the responsibility?
I wouldn't say any individual, but it's a collaborative thing. Because making guidelines, it's not just a another process. It has already been mentioned, it should come through our research and evidence-based, and at the same time, we are trying to do something which is going to suit our needs and our capabilities and our resources. By doing that, we should not have any compromise on the patient's outcome or the treatment outcome. So it's a very careful, we should do it very carefully without doing any, because patient is also very important here. We are not doing any harm to the patient, but at the same time, we are trying to suit our requirements.
So my question to Vivek Acharia, as the SAARC Secretariat is there in the Nepal. So why not having a good platform like SFO? So SFO, why not SFO should take some initiatives for doing this type of guidelines? What kind of hurdles you foresee to become to take the responsibility from the SAARC, SFO end?
I think yes, SFO can take the lead, but it must be research oriented, and research should be oriented according to our genome, as Dr. Babu has already said, right? I think that's a very good initiation India is taking. And I think we should have our own genome atlas from the SAARC country, which can direct our researchers, and from that conclusion, we can have a good guideline. But we had a guideline in our country. But again, it was a cut-paste and dose reduction alone does that. That's not going to help much, but I think it should be genome-oriented.
So Masood sir.
My view is that it should be through SAARC, SFO, SAARC Federation of Oncologists. The SFO should take the lead, and we should, the commonest cancer wherever, for example, cervix is common in Nepal, esophageal and stomach cancer is common in Afghanistan, head and neck cancer and breast cancer. So we can allocate these diseases to that country. The data should pool in that country, the one should lead from that country, and then those guidelines should be made. Because all the countries getting data to one place. So ultimately, this SFO will get all the data from all the countries, individualizing with each country. And then we can pool and get the guidelines.
Govind sir.
Suman, as Dr. Kamal said, we need basic epidemiological data first. And as you mentioned, 24% of the population of the world is from this region. And India is a large part for that. So I feel that, as we use the PAGA guidelines from ESMO, in India, we have ICMR guidelines, that is the Indian Council for Medical Research. This was in association with the National Cancer Control Program that these guidelines are developed. So we have another organization called the National Cancer Grid, which is a group of all the cancer centers across India. So we are now having guidelines through that as well. So, again, we are reinventing the wheel. So what I would say is if we have very specific differences in the regions and SAARC, we can adopt them into the guidelines that are already there. That's how I would put it across. And there's no point in reinventing the wheel again because we lose time and we will waste resources. So I think that is important. And as Dr. Ijaz said, the genomic thing, and Kamal, you just took us to the nice hospital yesterday where the facility is coming up. So I told you I'm getting ideas. So I think that is one of the things that we can collaborate on.
So we can get the Indian guideline as well and continue with that.
Yeah. So thank you, sir.
The other thing is, it should be what is called a living guideline. It's not time specific. It should be on the website. Most of it need not be printed. And as and when something new comes in, there is a committee for each one of the cancers, that looks into the new data that comes in and immediately updates it. Like for example, cervical cancer now. We have a data of the Interlay study which says that neoadjuvant therapy is useful in especially bulky cervical cancers. So we can't wait for another 2 years for the guidelines to get updated. So this concept of live guidelines is very important.
So rightly said, sir. You could see the NCCN guidelines procedure. So at the very end, you need the robust data. So you can see the process. So with this data, the panel meetings, updates, review, everything is come up. So we need our own data, and from this data we could develop our recommendations, whether it is category 1, category 2, or category 3, or etc., etc. So who should be involved in the guidelines development process? So let me back to the same question again. So if we think from today's meeting, so we are going to do something there. So what should be the procedures? What should be the structures? You can see the ESCO as their steering committees with their chairs, co-chairs, and the panels of members with their endorsing hospitals. So if you think, so Dr. Kamal bhai.
So, sometimes idea generates instantly. So just now the idea came to my mind that every year we are doing SFO meeting. And to be very honest, yesterday our chief advisor said that he wish all SAARC leaders stands and take a picture. So if I look at the scientific outcome of our SFO meeting, on a regional perspective, it's not that much I see there. So I request maybe this meeting we decide that from this year, one country will host the SFO meeting, another country hosts the guideline development meeting. So next year we develop on lung. The problem is we talk, we don't work because we live, we forget. So if we have one meeting for a day and we invite the people from all the SAARC countries like a SFO Congress, and there we sit only for one disease, and another is, as Govind was telling, to make life easy, let us take a regional guideline, say the Indian guideline, and we agree to make some small modification and see at the end of the year we report again what is the outcome of my country.
So that's a brilliant idea, Dr. F.M. Kamaluddin. So is there any suggestions? So how we could initiate, how could we proceed? Is there any other suggestions like F.M. Kamaluddin?
So how it was done by ICMR is they identified a chairperson for each disease and gave the option for the chairperson to form his team, and he could draw from all specialities across India. And most of it was online discussion, and we had every 3 months one meeting in Delhi where the whole committee members would come, and then it took us 2 years actually to finalize and publish that. So
Thank
that's
you,
how
sir.
it went on.
So suppose we could somehow manage to produce guidelines, the SAARC guidelines, how we are going to publicize it. So the ESCO has their own journals, the JCO, the SAARC region we don't have. The ESCO has their own website. So in the 19th SFO, we are sorry to say we don't have any common website. So how we are going to make this happen, sir? Responsibilities, the senior last two SFO President, Govind sir, Ijaz Masood sir, Vivek Acharya.
Frankly, I don't know, because we have never attempted this. But like I said, if you can draw what the other societies have done, like I told you what ICMR has done and what National Cancer Grid is doing. I'm a part of both the societies for guidelines. So that's how maybe you can draw parallels from that.
So from the meeting, can you initiate to develop a common SAARC website, SFO website? That is not a very tough thing, I think, sir.
You don't have to print it. Like I said, let it be on the website, and like I said, live guidelines. And as
Dr. Govind has already said, we can have guideline online. And
yeah.
Concludingly, if we join the version of Professor Kamal and Professor Govind Babu, we can have joint things. And keeping, as Dr. Kamal said, that lung cancer, Bangladesh takes lung cancer, and from each country, one specialized person can come and discuss there. So if we give one disease to each country, so that country will be responsible for that protocols or guidelines, and then they will manage the presence, maintain the presence of the people from all the other countries. And this is how each country can develop in 1 year or so. So we can get that guidance.
So thank you. At least we
So
could
one-
find. Sir,
Just
please.
one comment. I think, every time, like Dr. Kamal and Dr. has said, we always discuss and go away, nothing happens. So I think instead of starting several tumor types, let's start with one, take that as a pilot project and see how we do it over the next 6
So
months to 1
why
year.
not we are starting with lung cancer, sir?
Yes.
Because
Agreed.
Kumar Prabhas already initiated studies,
Agreed.
so I think we should start with this lung cancer plan.
Sure.
So that's the decision that we are going to start.
So-
Two things from these discussions. So we are going to create our own SOFO website.
And you take the lead.
Yeah.
You
Yeah.
take the
No, tomorrow meeting, probably we'll decide in our
Okay.
Yeah,
sure.
EC body.
Yeah, I think
And
SFO
we
should
will-
take the initiation,
Yeah.
the hosting country.
So thank you all the panelists. So now I would like to take the privilege. So we have got our Director of National Cancer Institute, Professor Jahangir Kobir. So may I request Professor Dr. Jahangir Kobir, Director of NICRH, so how he could help us to initiate this procedure, because you are right now representing the Bangladesh Cancer Institute. Please come over the dais and give your inputs.
Assalamu alaikum. I'm very happy to see our stars in the dais who deal with the cancer patient in this region. It is no question, it is essential for our region. Last day, I saw a patient who came with a polyp in the stomach. One gastroenterologist did polypectomy, and his stomach was involved with the cancer. Then the patient attended to the doctor. He went to a surgeon. He told, you go for surgery. Then he go to another oncologist. Told, no, you should go to, you should come to us. You should give 4-cycle chemotherapy. Then go for operation. Then he came to me. Sir, what should I do? I'm now in confusion. This is the reality. And that is the main cause of our patient going for third decision outside. So it is very essential to have own guideline. And now, because in stomach cancer, our country practice is sometimes we go for maintaining the NCCN, sometimes we go for the Japanese guideline. So the patient become confused. In breast cancer, all the time we cannot follow the NCCN guideline, because if it is a lump size is to 2 centimeter TNBC, in NCCN guideline you should go for neoadjuvant chemotherapy. But before that you should give hydromark. It is very difficult to put hydromark in all over the country. Only some center in Dhaka we have that facilities. So for preparing guideline, I think we should consider the resources, patient's educational status, patient family background, and our expertise. So I think it is very essential to develop a guideline and how we can do it. So you the professors rightly mentioned, we can set a senior or expert person who can then adopt to expert from that subject. That is Delphi's method. You can recruit some or adopt some expert person, then you can just prepare a guideline, then publish it in website. Then after some feedback from the oncologist and surgeon, you can finalize it. And it is not fixed. We can update in 6 monthly, on yearly, we can update it. Because for no treatment is fixed. Today that is right, tomorrow that may not be right. So I want to thank the organizer to arrange such a discussion. I think SFO, SAARC Federation Oncology, is the very right platform to go ahead with this formation of guideline for our region. And every 1 year, 2 year, we can sit and we can modify this guideline. And as director of NICRS, our hospital is solely concerned with the treatment and treatment of cancer patients. We have a lot of data, but unfortunately, we have not we have data not centralized. So we have only hospital-based data, no population-based data. So we can help in this regards how we can set a guideline for our country. Thank you very much.
So thank you, Director of NICRH. Now I would like to request Professor David Coleridge, the Chief Editor of Lancet Oncology, to give directive words to this initiative. David Coleridge. David Coleridge, yes, come over the dais.
He will publish. We write, he will publish.
Thank you very much. Regional guidelines, absolutely vital. We carried out an exercise many, many years ago in Asia Pacific, where we looked at creating a series of GDP-adapted guidelines for the region. And we looked at 12 different cancers across those countries. And those guidelines were really, really vital because you could create these single guidelines, but with adaptations. So for Vietnam, one thing, for Singapore, another thing, for Thailand, another thing. And I think what you're suggesting here is very similar to that. And wrapped into there, adapting the Indian guidelines, and Dr. Babri, you're absolutely right. You know, there's no point reinventing the wheel. We've got a good head start there. And also in India, there has been a really interesting project on the Choosing Wisely campaign. And I think that would be a nice exercise for the SAARC region to look at. You know, what are those activities that are done, but actually they're not very cost effective, they're not actually very clinically effective, but for all sorts of cultural reasons they're done. So it'd be a nice exercise to look at what you could rationalize. So I fully endorse what's going on. I think this is a really great activity for the SFO to take forward, and I wish you the best of luck.
So David, Dr. Govind was telling that once we work on it, we write it, you publish it. That is how we finish it.
So let's hear from our chairperson, Professor A.M.M. Shariful Alam, sir.
My comments?
Yes, sir.
From today's discussion, two important topics comes out for discussion: developing guidelines and collaboration. Definitely we need the guidelines in considering our countries as well as the SAARC countries. You already mentioned previously that we are following NCCN guidelines or ASMO guidelines, etc., etc., etc. But considering the demographic characteristics, socio-cultural habits, and dietary habits, definitely we should have a separate guidelines in the context of SAARC countries. So we have to take relevant steps to make a proper guidelines for our regions. Then the question comes, how to start? So we should make a first step regarding making a guidelines. I think to develop a guidelines, in the context of SAARC countries as well as our countries, we need to start a guidelines. We should discuss it in the tomorrow's SFO meetings. And my comments about developing a national guidelines, we can initiate the process by asking or requesting all the societies, oncological societies, as for example, surgical oncology, medical oncology, hematological oncology society, etc., etc., to make, we can make a letter from the oncology club or from the NICRH director is here, he can take the initiatives to start this process, as because this is the that when I was director, at that time the secretary of the Ministry of Health told that the director Cancer Institute is the leader of the country in oncology sector. Now he is the director, so he can take the initiatives if he is interested. Otherwise, it is very difficult to develop a national guidelines individually or from any other individual societies. So I think we should discuss or we should think about it in developing a guideline at the national levels. And I hope in the tomorrow's SAARC meeting, SFO meeting, we will discuss how to start our journey. As because SFO has been started his journey about more than 20 years back. But still today, there is no development. That's why now as a president of the SFO, I think we should do something. Otherwise, we are doing meetings and we are doing conferencing each and every year, but we are not providing any sorts of support or any contribution for the country and as well as for the SAARC regions. So we should start something at the national level and the regional level. So at the national level, I am giving my proposal, and in the next meeting, tomorrow's meeting, we will discuss regarding this matter. Thank you.
Thank you, sir. Sir, last words from Professor M.A. Hai, sir, the patron of SFO.
Bismillahirrahmanirrahim. So long we have discussed about the necessity of guideline in our region, in our country, and everywhere. We can make a guideline, no problem. But are we ready to implement it? After making the guideline, so can we say that everybody shall have to follow this? There is a big problem. We shall have to equip us first, that how we equip them, then we can implement it. So I am treating in a hospital, there is no radiation, no surgeon, only chemotherapy I am trying to do. But even then I cannot employ all the types of chemotherapy. Patients have different financial stage. So if we can provide medicine, if we can provide radiation treatment, we provide surgeon, then we can make it definite, follow this guideline. So we shall have to equip ourselves. And I don't agree with Dr. Shariful Alam that we didn't do anything for so long. We have done a very lot, so we have much improvement. Lots of our youngsters are coming up. People are getting interested in oncology, and we have seen the boys are doing the lectures. Only thing we shall have to nourish them, shall have to guide them, that's it. So guidelines are there, many guidelines are there in many countries. We can try to develop our own guidelines as well. So at least we need that we have, I'm happy that you have felt that we need a guideline. I have proposed that we shall be guideline, but we shall have to equip ourselves. This is the first thing. So I think Dr. NICH, Director NICH, if he takes the initiative, but I have every doubt, if he remains so busy, it is very difficult to spare time to make a guideline for this. He must have his own committee for this. If you have that committee, you cannot do it. So if our next tomorrow's meeting, we shall try to find out something how can do it. But before that, we shall have to equip ourselves. That is the main thing. Analytics, my suggestion will be to follow the guideline of Allah subhanahu wa ta'ala. That guideline is for everything, everybody, everywhere. Anybody can follow the guideline. So thank you all very much. We have had a lot of discussion, and hopefully we shall have our guidelines, and we shall follow it. We shall be able to equip ourselves, all the contributors, and so forth. Thank you all very much.
So thank you, sir. So I must acknowledge these two guys, Professor Kumar Prabhat sir from Tata Memorial College, Tata Memorial Cancer Hospital, Mumbai. He has given all his supports to prepare these slides. And what to say, this young man, Dr. F.M. Kamaluddin, he always guide me always as usual, so preparing the slides. So thank you all for your precious time. Thank you.